Okay, let's unpack this. Welcome to the deep dive, where we slice through dense medical information to find the crucial insights you need. Today, we're diving into a topic that's, well, fundamental for future medical professionals like you. The surprising and absolutely vital connection between common viruses and cancer. It's more than just memorizing facts. It's about grasping the root causes of disease and understanding how a tiny entity can wreak such long-term havoc.
Exactly. And this deep dive into human papillomavirus, or HPV, and its profound role in cervical cancer isn't just theory, not at all. It's about understanding the fundamental disease mechanisms that directly impact patient lives and really inform our approach to prevention and treatment.
So, let me put a thought into your mind right from the start. Think about, say, a common cold or the flu. Most viruses cause a temporary illness, your body fights them off, and then they're gone, right? Pretty straightforward. But what if a virus stayed? What if it quietly began rewriting the very rules of your own cells, eventually leading to something as serious as cancer? How could a microscopic entity achieve such a monumental long-term change, like essentially taking over a cell's destiny? Keep that question brewing. We'll definitely circle back to it.
That's really the core mystery we're exploring today. Our mission, if you will, is to illuminate that exact association between viruses and cancers. Specifically, we'll be delving into the pathophysiological mechanisms of HPV infection and how it drives the development and spread of cervical carcinoma. And we'll arm you with some memorable metaphors, anchors, and acronyms along the way. Things tailored to help you, as first-year medical students, understand, retain, and, importantly, recall this critical information.
Okay, here's where it gets really interesting. Before we even introduce our viral culprits, we need to understand the battlefield. Our own cells. I mean, our cells are constantly dividing, growing, replacing themselves. It's an incredibly precise, highly controlled process managed by this intricate cell cycle machinery that dictates exactly when and how cells proliferate.
And that's precisely where cancer makes its insidious entrance. Simply put, cancer is a disease of inappropriate, uncontrolled cell proliferation. What's truly astonishing, though, is how a tiny genetic error can essentially, well, unlock a cell's normal controls, turning it into this engine of uncontrolled growth. That's where the concept of an oncogene comes in. It's genetic material that carries the ability to induce cancer. To visualize this, maybe imagine the cell cycle as a finely tuned cellular orchestra. Every gene is like a musician, playing their part precisely, ensuring harmonious growth. An oncogene, then, is like a rogue musician, maybe with a broken instrument, just playing out of control, totally disrupting the entire performance. Leads to that unchecked growth.
Right, the rogue musician. I like that. And among the most crucial conductors in this cellular orchestra, a key player you absolutely need to understand is a protein called P53. This protein acts like the ultimate guardian, doesn't it? Making sure everything stays in tune.
Absolutely. Couldn't have said it better. We often refer to P53 as the cell cycle traffic cop, or sometimes the guardian of the genome. Its job is crucial. It operates at key checkpoints in the cell cycle, specifically the G1S checkpoint, that's where a cell decides whether to divide, and the GTM checkpoint, just before division. It's making sure everything is in order before a cell replicates its DNA and divides.
So how does it actually do that? What's the mechanism?
Well, P53 exerts its effect mainly through another protein, P21, and P21 inhibits cyclin-dependent kinases, or CDKs. These CDKs are the enzymes that push the cell cycle forward. So P21 effectively puts a pause on the process, like hitting the brakes. This pause is critical. It allows time for DNA repair if damage is detected.
Okay, so it pauses for repair. But what if the damage is too bad?
Great question. If that DNA damage is too severe, just irreparable, P53 shifts gears. It goes from repair mode to self-destruction mode. It promotes apoptosis, that's programmed cell death, by inducing pro-apoptotic genes like BAX and activating caspases. Caspases are basically the cell's internal executioners. They dismantle the cell cleanly.
Executioners, wow, that's dramatic but clear.
It is. And for you, our students, a really helpful way to remember P53's many functions is the acronym PROTECTS. Stands for pauses cell cycle, repairs DNA, organizes apoptosis, terminus for damaged cells, ensures genomic integrity, controls proliferation, tumor suppressor, and safeguards the genome.
PROTECTS. Okay, that really nails down its vital role. So thinking about that acronym, let's revisit that earlier thought. What happens to the whole cell cycle, all that cellular traffic, if our vigilant traffic cop, P53, is suddenly taken off the beat? What's the immediate danger there, and how does that link back to cancer development?
Right, well, to answer that directly, if our cell cycle traffic cop is gone, if P53 is inactivated or lost, the cell loses its crucial checkpoints. It's like Traffic lights all turning green. DNA damage goes unrepaired. Damaged cells that should have been stopped, continue to divide. This leads to unchecked, inappropriate proliferation. It basically creates the perfect storm for cancer development because there's no guardian left to halt these rogue cells.
The perfect storm. Okay, that paints a picture. So having laid that essential groundwork on cell control, it's time to bring in our key players, the viruses themselves. Because, as we hinted, some are just passing invaders. They are truly master manipulators.
That's a crucial distinction, absolutely. We're talking about oncogenic viruses. These are specifically defined as viruses that can cause cancer by altering the genetic material of the host cells they infect. We can think of them as our viral cancer rogues gallery. These are the viruses that don't just cause, a quick illness, but can silently trigger cancer, often years, sometimes even decades after the initial infection.
And this gallery includes some names you'll definitely encounter in your medical careers, some of them surprisingly common, actually.
Indeed. First, the star of our deep dive today, Human Papillomavirus, HPV. It's a leading cause of several cancers: cervical, anal, oropharyngeal, vulvar, vaginal, and penile cancers. And the high-risk types, like HPV-16 and HPV-18, those are the main culprits we worry about.
Okay, HPV is top of the list. Who else is in this rogues gallery?
Well, there's Epstein-Barr Virus, EBV, often linked to Burkitt lymphoma, Hodgkin lymphoma, nasopharyngeal carcinoma, and even some gastric cancers. Its mechanism usually involves latent infection, hiding out in B cells and epithelial cells.
Right, EBV. And we can't forget the hepatitis viruses, can we? Hep B and Hep C.
Definitely not. Hepatitis B virus, HPV, and Hepatitis C virus, HCV. Both are major players in hepatocellular carcinoma, that's liver cancer. Their mechanism involves chronic infection leading to liver cirrhosis and that persistent inflammation and fibrosis. It just creates a fertile ground for cancer.
Chronic inflammation seems to be a recurring theme.
It often is. Then we have human T-cell lymphotropic virus type 1, HTLV1. This one causes adult T-cell leukemia lymphoma, or ATLL. It does this by actually integrating its viral DNA into the host T-cell genome.
Integration. We'll come back to that with HPV.
You bet we will. Another important one, Kaposi's Sarcoma-associated Herpesvirus, KSHV, also known as HHV8, responsible for Kaposi sarcoma, primary effusion lymphoma, and multicentric Castleman disease. Again, usually through latent infection, this time in endothelial cells.
Okay, so KSHV. Any others for the gallery?
One more key one for this list is the Merkel Cell Polyomavirus, or MCV. A bit more recently identified, but it causes Merkel cell carcinoma. And its mechanism, again, integration of viral DNA leading to mutations.
Wow. It's quite a list, isn't it? Each with its own sort of preferred target and method of sabotage.
Exactly. A diverse group, but all sharing that dangerous ability to push cells towards cancer.
Okay, so let's focus our deep dive now squarely on HPV. As you said, arguably the most infamous member of our viral cancer rogues gallery. And it's incredibly common, often surprisingly so. HPV is the most common sexually transmitted infection out there. So ubiquitous that, get this, an astonishing 80% of sexually active, unvaccinated men and women will acquire the virus at some point in their lives.
80%, it's a huge number.
80%. That's almost everyone. It really brings home how easily these silent threats can spread, often without anyone realizing until much later when it might become something far more serious.
It truly is. And HPV is broadly classified, as we mentioned, into high-risk and low-risk types. Transmission is primarily through direct contact with infected skin, like skin-to-skin contact. For testing, it's generally a visual exam for males, though that can be difficult. For females, it involves a visual exam and, crucially, detection through cervical smears, like the Pap test or HPV testing.
And it's important to distinguish the forms it takes, right? Many people are familiar with the benign manifestations, the warts. Like condylomata acuminata, those are anogenital warts, most often caused by the low-risk types, like HPV 6 and 11. These warts typically appear maybe 1 to 6 months after infection. Visually, they're usually soft, moist, tiny pink or gray polyps. They can enlarge, sometimes become pedunculated stalk-like, often have rough surfaces, might appear in clusters. And while they're usually asymptomatic, some patients do experience itching, burning, or discomfort. You see them in various locations, genitals, anal regions, both men and women.
It's exactly. But in stark contrast, the high-risk types like HPV 16 and 18, they usually cause flat, often invisible lesions, especially inside the cervix or anus. These are clinically difficult to see without specific examination techniques, like colposcopy. And these are the ones strongly linked to malignancy. So this raises an important question for you, our listeners, to ponder. We know HPV is incredibly common and sometimes just cause warts. But not everyone who gets HPV develops cancer. What's the fundamental difference? Between the wart-causing HPV types and the cancer-causing ones, what is actually happening inside the cell that makes this critical distinction? We'll get to the answer soon.
That's a critical question, definitely. But first, let's talk about the path, the progression of cervical cancer. It typically starts with something called Cervical Intraepithelial Neoplasia, or CIN. You can think of CIN as a kind of ladder to cancer. It's a graded scale of abnormality that clinicians use to understand the severity and progression of these cellular changes.
Exactly. CIN is diagnosed based on histology, looking at the tissue under microscope. And it has 3 grades. CIN grade 1 is mild cervical dysplasia, considered low risk. Many of these regress on their own. CIN grade 2 is moderate dysplasia, getting more serious. And CIN grade 3 is severe dysplasia or carcinoma in situ, CIS. In situ means in its original place. So the cancerous changes involve the full thickness of the epithelium, but crucially, it hasn't invaded beyond the basement membrane yet. CIN2 and especially CIN3 are considered high risk. CIN3 particularly is unlikely to just regress spontaneously. If left untreated over months or sometimes years, it can penetrate that basement membrane, becoming an invasive carcinoma.
And is there something specific doctors look for under the microscope that screams HPV?
Yes, there is. A key microscopic fingerprint of HPV infection that you'll learn to identify is the koilocyte. This is a squamous epithelial cell that's been transformed by HPV. It looks distinct. It has condensed chromatin in the nucleus and often this characteristic paranuclear halo, almost like a clear bubble around the nucleus. Seeing koilocytes on a pap smear is a very strong indicator of HPV infection.
Koilocytes. Got it. Now, beyond the virus itself, are there other things that increase the risk of this CIN progressing to cancer?
Yes, definitely. Certain risk factors seem to accelerate this progression. These include things like starting intercourse at a younger age, having a high lifetime number of sexual partners, also cigarette smoking is a big one, and having a weakened immune system, maybe due to HIV or certain medications. But it's really important to recognize that regardless of a woman's specific sexual history, clinicians should just assume exposure is possible because HPV is so incredibly widespread.
Right, assume exposure. And what about symptoms? If it progresses to actual cervical cancer, what might a patient notice?
That's the tricky part. It's often asymptomatic in its early stages, which is exactly why regular screening is so vital. We catch it before it causes symptoms. As it progresses, though, irregular vaginal bleeding is a common sign. Maybe bleeding after intercourse, between periods, or after menopause. Larger cancers are more likely to bleed spontaneously and might cause a foul-smelling vaginal discharge or pelvic pain. If the cancer becomes more widespread, it can cause obstructive uropathy problems with urine flow leading to back pain and even leg swelling due to venous or lymphatic obstruction. On a pelvic examination, a doctor might actually see an abnormal growth, maybe an exophytic necrotic tumor in the cervix.
Okay, so screening is key because the early stages are silent. Now let's get to the how, the molecular biology. How does HPV actually turn a normal cell into a cancerous one? This is where the virus performs that true molecular hijack you mentioned, right? Cleverly manipulating our own cellular machinery.
This is really the heart of the matter, the core mechanism. It begins when HPV infects epithelial cells, typically in the cervix, usually getting in via tiny microabrasions. It attaches to the cell surface and enters the cells through structures called clathrin-coated pits via endocytosis, basically. The cell membrane folds inwards and engulfs the virus. Now, initially, the viral DNA can remain episomal. That means it exists separately from the host cell's DNA, kind of like a little circular plasmid floating around in the nucleus. In this episomal state, a viral gene called E2 plays a crucial role. E2 acts like a regulator, keeping the expression of the main viral oncogenes, E6 and E7, in check. It keeps them quiet, relatively speaking.
Okay, so E2 keeps E6 and E7 under control when the virus is just floating around episomal. What changes?
The critical step. The game changer in oncogenesis occurs when the viral DNA integrates into the host genome. It inserts itself, becoming part of our own DNA. This integration process often, and crucially, results in the disruption or deletion of that viral E2 gene. Think of the E2 gene as the viral brake pedal. When the viral DNA integrates and E2 is disrupted, that brake pedal is suddenly gone. There's nothing holding back E6 and E7 anymore.
The brake pedal is gone, so uncontrolled acceleration.
Precisely. The consequence of E2 gene disruption is the uncontrolled massive overexpression of the viral oncogenes E6 and E7. And these two proteins are the real villains here. E6 specifically seeks out and binds to our cell cycle traffic cop, the tumor suppressor protein P53. And it doesn't just bind it, it promotes its degradation, basically tells the cell to destroy P53. So a good anchor for this is E6 degrades the guardian.
Destroys P53. Okay, that's bad. What about E7?
E7 targets the other major tumor suppressor protein we discussed implicitly, RB, the retinoblastoma protein. E7 binds to RB and causes its inactivation. RB normally acts as a cellular gatekeeper. It puts the brakes on the cell cycle, preventing progression from the G1 phase into the S phase, where DNA replication happens, unless everything is okay. E7 essentially pries RB off its target, releasing the brakes. So our anchor here, E7 releases the brakes on RB.
E6 degrades P53, E7 releases the brakes on RB.
Exactly. The combined outcome of these interactions, losing P53's checkpoint control and apoptosis function and losing RB's gatekeeping function, is devastating for the cell. The cell is pushed prematurely into the S phase, DNA replication happens without proper checks, and you get unregulated, unimpeded cell growth. That's the transformation into cancer.
Wow, okay, so now we can answer that earlier question, right? The difference between the wart-causing HPV and the cancer-causing HPV.
Yes. Now we can put it together. The key difference lies in their molecular strategy, particularly regarding integration in that E2 gene. Low-risk types, like 6 and 11 that cause benign warts, generally keep their DNA episomal. Their E2 gene usually remains intact, effectively regulating E6 and E7, keeping them in check. They don't typically integrate into the host genome in a way that breaks E2. But the high-risk types, like 16 and 18, they are the master manipulators. Their integration into the host genome frequently disrupts E2. This unleashes E6 and E7 to specifically target and disable our cellular guardians, P53 and RB. That's what paves the way for cancer. It's that precise, devastating molecular hijack targeting P53 and RB that the low-risk types just don't typically achieve.
That makes so much sense now. The integration and the loss of the E2 brake pedal are the critical events for the high-risk types. All right, understanding the enemy is half the battle. The other half is detection and prevention. Let's pivot now to how we combat this threat, both individually and on a public health level.
Absolutely. And when we talk about cervical screening, it's so crucial to understand and for you to explain to future patients that it's not primarily a test for cancer. Rather, it's a powerful method of preventing cancer. How? By detecting and treating those early abnormalities, the CIN lesions we talked about, before they ever get the chance to become cancer. The procedure itself usually involves a speculum to gently open the vagina for a clear view of the cervix, and then a small brush or spatula is used to collect a sample of cells from the surface and the opening of the cervix. Most women find it just mildly uncomfortable.
And how does the testing work now? Has it changed?
It has evolved. In many places, like England, Scotland, and Wales, primary screening now starts by testing the samples specifically for the presence of high-risk HPV DNA. If high-risk HPV is found, then they look at the cells under the microscope, cytology, for abnormalities. The next steps are tailored to your individual risk based on those combined results. If abnormalities are found either through HPV testing or cytology, the next step is often a colposcopy. This uses a special magnifying instrument, a colposcope, to get a much closer, illuminated look at the cervix, allowing the doctor to see abnormalities not visible to the naked eye. They might apply solutions like acetic acid to highlight abnormal areas.
Okay, colposcopy for a closer look. What if they find abnormal cells that need removing?
Then a procedure like LEAP, which stands for Loop Electrosurgical Excision Procedure, might be performed. LEAP uses a thin, low-voltage electrified wire loop to cut away the abnormal tissue from the cervix. Think of LEAP as like a targeted surgical scalpel, precisely removing those rogue cells, the CIN lesions, from the cellular orchestra before they can completely disrupt the performance and progress to invasive cancer. It's usually very effective for treating high-grade CIN.
Targeted scalpel. Good visual. Now, prevention is truly where we see the immense impact of understanding HPV, right? And the single best tool we have. Vaccination. It feels like one of the most impactful public health interventions of our time regarding cancer prevention.
Without a doubt. The HPV vaccine is recommended for a broad population to maximize its impact. This generally includes all children around age 12 or 13, before most are likely to be exposed to the virus. Catch-up vaccination is often available for older adolescents and young adults, say girls and women up to age 25 or 26, and boys and men too. Recommendations also often include specific groups at higher risk, like men under 45 who have sex with men, and transgender people. The primary goal is to vaccinate against the highest risk, most common cancer-causing types, primarily HPV 16 and 18, which cause the vast majority of cervical cancers, plus often types 6 and 11 for wart prevention.
So vaccinate early and broadly. And it's crucial, as you mentioned earlier, to remember that HPV's reach extends far beyond the cervix. While cervical cancer gets a lot of attention, this virus is a vanguard for other significant malignancies, too.
That's a vital point we can't stress enough. For example, looking at oral cancers, maybe 25% to 35% of them in places like the UK are now HPV-related. And interestingly, these HPV-positive oral cancers are often seen most commonly in heterosexual men in their 40s and 50s. It's changing the demographics of that cancer.
And what about anal cancer?
Anal carcinoma is another major concern. The incidence seems to be increasing. And the link to HPV is incredibly strong. Approximately 90% of anal cancer cases are linked to an HPV infection. Again, HPV-16 is the most common genotype found. Now, most HPV infections, even anal ones, won't develop into cancer. But other risk factors definitely play a role. Being over age 50, having other cancers or precancers, a weakened immune system, like from HIV or immunosuppressant drugs, chronic anal inflammation or abnormalities, multiple sex partners, receptive anal intercourse, and smoking. We've seen public figures like actress Marcia Cross bravely share her anal cancer diagnosis. She suspected it was linked to the same HPV strain that caused her husband's throat cancer. It's a powerful reminder that transmission routes can be complex, and it's not always linked just to specific sexual practices. Awareness is key for everyone.
Absolutely. Okay, this has been a whirlwind deep dive, but truly illuminating. It shows the profound impact of this tiny virus. Just to quickly recap some core points for everyone listening. HPV infection, particularly high-risk types, causes CIN, which can potentially lead to invasive cervical carcinoma. We've seen how HPV isn't just about the cervix. It's linked to various cancers, including anal and oropharyngeal carcinomas. Critically, we now understand the how. HPV oncogenes E6 and E7 interfere with our key tumor suppressor proteins, P53 and RB, actively driving that cancerous growth by disrupting cell cycle control and apoptosis. And finally, and perhaps most hopefully, screening detects precancerous changes, and vaccination prevents infection in the first place. Both are absolutely crucial tools.
Exactly.
Yeah.
And to summarize the impact of understanding this virus-cancer link, early detection through effective screening programs can dramatically reduce the risk of invasive cancer developing. It saves lives, period. Moreover, public health initiatives that focus on increasing vaccination rates, especially in young adolescents, and raising awareness about HPV and its risks. These are immensely powerful tools in our collective fight against these cancers. It's a true success story, really, of translating molecular biology insights into effective public health action.
So what does this all mean for you listening in as a future medical professional? Well, it means that understanding this intricate dance between a virus and our own host cells isn't just academic jargon. It's truly fundamental. Fundamental to diagnosis, to treatment decisions, and perhaps most importantly, to prevention and patient education. This knowledge empowers you to explain risks, recommend screenings, advocate for vaccination, and ultimately help save lives. Your role in translating the science into tangible patient benefits is immense.
Absolutely. Every patient interaction where you discuss screening, every vaccination recommendation you make, every cytology report you interpret, it's all built on this foundational knowledge. It allows you to see beyond just the symptoms or the test result and understand the deep cellular mechanisms that are actually at play.
So let's end with this thought. Imagine a future where HPV-related cancers become a rarity. Not necessarily because we found some miracle cure for advanced cancer, but because we truly understood the virus, because we embraced vaccination widely, improved our screening methods, and empowered individuals and communities with knowledge. How does this deep dive into the story of HPV change your perspective on the incredible power and maybe the responsibility of prevention in the practice of medicine? Something to think about.